Welcome to this presentation on Electrophysiology Foundation Session 1.2. Why do arrhythmias occur? Just as a heart has many fail-safe mechanisms with it, there are several ways in which electricity may travel abnormally through the heart. Arrhythmogenesis is defined as the development or onset of an arrhythmia or abnormal rhythm within the heart. We can identify the origins of these tachyarrhythmias, most often seen, by understanding the unique properties of cardiac cells that will sustain these abnormal rhythms. Remember that SVT, or supraventricular tachycardia, is a blanket term that only indicates a fast heart rhythm originating from above the ventricles, but we can determine with more specificity what type of SVT rhythm is observed. The surface ECG is limited in being able to narrow down the type of SVT, and this is where EP studies have become valuable in defining the location and also providing treatment. The use of EP studies has opened the door to creating a cure for many arrhythmias, as we can locate and eliminate the substrate that initiates or maintains the rhythm. With understanding the arrhythmogenesis mechanism of an arrhythmia, SVT becomes a term that you will need to use less often. We will discuss the three main mechanisms: abnormal automaticity, re-entry, and triggered activity. Automaticity is a unique property of cardiac cells that allow the cell to spontaneously depolarize. As each cardiac cell has its own rate of depolarization depending on the location within the heart's electrical conduction system, when there is abnormal automaticity, phase 4 of the action potentials are abnormally accelerated. This accounts for approximately only 10% of abnormal tachyarrhythmias. When we think of an ECG tracing, we will see a clear warm-up onset and offset or cool down of the arrhythmia, such as a more gradual increase and decrease in heart rate variation. Automatic arrhythmias are most often due to metabolic disorders such as acute ischemia, hypoxemia, electrolyte imbalances, high sympathetic tone that may be transiently caused by general anesthesia, and the use of sympathomimetic agents. Due to the origins of these arrhythmias, it is difficult to reproduce these parameters to induce the arrhythmia. We see this type of arrhythmia predominantly in acutely ill patients as a result of metabolic reactions to the setting. The most common arrhythmia seen is multifocal atrial tachycardia that is typically seen with patients exhibiting pulmonary disease patterns. Some arrhythmias, such as inappropriate sinus tachycardia, atrial tachycardia, junctional tachycardia, and some ventricular arrhythmias noted post-acute myocardial infarction, have been thought to be due to abnormal automaticity, as once you remove the underlying cause of the abnormal automaticity, the arrhythmia will cease. This slide shows a graphical representation of the action potential identifying the process of abnormal automaticity occurring during phase 4, which precipitates the normal cardiac cycle rates. Notice that the x-axis or horizontal values indicate the time in milliseconds. In the EP world, we discuss cardiac cycle lengths in milliseconds.
The second type of arrhythmia mechanism, and the most commonly seen, is reentry. Reentrant arrhythmias account for the highest rate of mortality based on the study of tachyarrhythmias. Due to the makeup of reentrant arrhythmias, we are fortunate to be able to reproduce the characteristics in the EP lab and gain more understanding in recognizing and treating these arrhythmias. Going back to envisioning the surface ECG, we can observe a definite onset and offset of these arrhythmias, meaning they are paroxysmal in origin. Typically, the onset shows a premature impulse. Remember that paroxysmal means an abrupt beginning and end. The substrate for reentry involves particular criteria. Two parallel electrical pathways create the potential for circuit movement or looping of circuits. One pathway will have a slower conduction velocity and faster recovery period, and the other pathway will have a faster conduction velocity with a slower recovery period. Due to the slower recovery period of faster conducting pathways, the faster conducting pathway will usually be the first one to block in response to an early extra stimulus. The required underlying substrate that allows a reentry circuit to sustain are those two parallel pathways with critical variance in conduction velocities and refractory periods discussed in the previous slide. The requirement to initiate a reentry circuit is for a premature impulse to block in only one of those pathways in a particular direction, due to that pathway being in its effective refractory period, and for the signal to reenter that initially blocked pathway in the opposite direction once it is electrically recovered. Rhythms initiated by reentry include, but are not limited to, AVNRT, AVRT, atrial flutter, and most ventricular tachycardias. Reentry ventricular tachycardia is most often seen in patients with a previous MI or in patients with cardiomyopathies. Both disease patterns will produce areas of scarred myocardium that prevent normal electrical activation. Reentrant circuits can then be created along the borders of normal myocardium and scarred tissue, or may also involve an accessory pathway.
Ventricular tachycardia is an important arrhythmia because it is the cause of most sudden cardiac deaths, and reentrant is the mechanism for most episodes of VTAC. Newer ventricular mapping techniques are making it possible for the reentrant circuits in some patients to be located, ablated, and cured. The image attached shows the onset of VT from a sinus rhythm. As previously learned, ischemic conditions will provide the substrate for a reentrant arrhythmia. This image zooms into the border along scarred myocardial tissue and healthy tissue. Remember that scarred myocardium will not conduct impulses normally and create an altered conduction velocity, which promotes the development of reentrant circuits. One unique way to remember the substrate for reentry is to picture yourself jogging on a track at a slow, comfortable pace. Chances are, after you complete a set distance, you will not need much time to recover. Now picture yourself running the same distance as fast as you can. Chances are you will need more time to catch your breath. This ECG shows a narrow, complex tachycardia with notching seen that is characteristic of AVNRT. AVNRT is most commonly seen with women. There are two types of AVNRT defined by the root of the depolarization. The most common type is known as slow-fast AVNRT, which indicates that the impulse traveled down the slow pathway and then up the fast pathway. The other type of AVNRT is fast-slow AVNRT, which indicates that the impulse traveled down the fast pathway and then up the slow pathway. Specific to a slow-fast AVNRT, the slow pathway tends to have a shorter effective refractory period that will be depolarized by an early premature impulse, as the impulse will catch the fast pathway still in recovery due to its longer refractory period. If the timing is right, once the impulse gets to the His bundle, the fast pathway may finally not be refractory anymore and may conduct the impulse retrogradely to the atria. This would cause an atrial echo beat. If the slow pathway is recovered from the early PAC that initiated the rhythm, which is likely due to a propensity to have a quick recovery period, it may conduct antegrade back down the slow AV nodal pathway to the His bundle. If timing is right, this will cause a reciprocating tachycardia through the AV node caused by reentry. It is worth mentioning that each time in this cycle that impulses travel through the AV node to the atria, they are being depolarized, although the P wave is difficult to locate on the surface ECG due to its close proximity to the end of the QRS. When locatable throughout the arrhythmia, the P waves will be seen retrograde in lead 2 and seen as a notch close to the end of the QRS complex. Successive complexes will have a retrograde P with a shorter RP than PR interval. This P wave is often discussed as a pseudo R prime due to its location at the end of the QRS complex. This patient's previous ECG in normal sinus rhythm will not show this pseudo R prime configuration.
AVRT, or atrioventricular reciprocating tachycardia, occurs in patients that have an extra conduction pathway known as an accessory pathway, which is located outside of the AV node. This occurs in approximately 1 in 1,000 people. We can define the 4 types of these accessory pathways from the atria to the ventricles, described by their location along the atrioventricular groove. Note the image shows all 4 types of conduction pathways, with the most common type being AV bypass tracts. Tract A represents an AV bypass pathway that connects the atria directly to the ventricles. Tract B represents an AV nodal pathway that connects the atria directly to the bundle of His. Tract C is a Mahaim pathway that connects the atria near the AV node directly to the right bundle branch. And Tract D is a pathway that connects the distal pathway from the His bundle to the ventricles.
Discussion of an AVRT arrhythmia requires clarification of WPW. As we have previously learned, Wolff-Parkinson-White syndrome occurs when someone has an accessory pathway across the AV septum, also known as AV bypass tract, and that accessory pathway is able to conduct antegrade. This often gives us the appearance of a delta wave, also known as pre-excitation, and short PR interval in normal sinus rhythm. Patients with WPW may be at risk for more trouble than just AVRT. Consider how the AV node provides protection from the fast atrial rates in atrial fibrillation. If we bypass that protective structure, the ventricular rate in atrial fibrillation in a patient with an accessory pathway that conducts in the antegrade direction depends solely on the refractory properties of that accessory pathway. In AVRT, when the signal is traveling antegrade through the accessory pathway and retrograde through the AV node, you will see wide QRS complexes and a regular rhythm. This is called antidromic AVRT, as shown in the ECG. This rhythm may be difficult to distinguish from VT on a surface ECG. Remember that 80% or more of all wide complex tachycardias are ventricular tachycardia and should be treated as such unless another mechanism can be proven. This ECG represents orthodromic AVRT, which defines the impulse pathway as conducting antegrade through the AV node and retrograde through the accessory pathway. This is described as a concealed pathway, as we do not see the classic delta wave pattern seen with antidromic AVRT or WPW in sinus rhythm. On the surface ECG, we can only see a characteristic narrow complex QRS with no discernible P waves, but the T wave morphology in V1 suggests a buried T wave with a longer RP than PR interval. A previous ECG is the most important tool in determining the presence and location of buried P waves. This ECG shows atrial fibrillation with rapid ventricular response via the accessory pathway, or antidromic WPW. One cardiologist has described this rhythm as the only rhythm that can produce so much ink on an ECG. The slurring delta waves are present with an irregular ventricular response. The AV node is completely bypassed, allowing rapid atrial rates to depolarize to the ventricles. Without the protection of the refractory properties of the AV node, this rhythm can quickly overwhelm the ventricles, causing ventricular tachycardia, ventricular fibrillation, and death. Here we can visualize the depolarization pathways of AVRT with orthodromic and antidromic conduction. Which arrhythmia mechanism is easiest to induce in the EP lab? The answer is re-entry. Which arrhythmia mechanism is most difficult to induce in the EP lab? The answer is enhanced automaticity. Atrial fibrillation displays an irregularly regular RR pattern with no discernible P waves. Continuous atrial activations are depolarized from both atria. We will focus on the recognition of ECG characteristics and discuss in later slides ablation of AF. Atrial fibrillation is generally precipitated by conditions of atrial enlargement, and many impulse sites are within the pulmonary veins, and ablation procedures will focus to electrically isolate the pulmonary veins to eliminate ectopy from entering the left atrium. Atrial fibrillation is normally initiated by a PAC, as in most paroxysmal reentrant atrial arrhythmias. Initiation of these PACs include the mechanisms of enhanced automaticity, EADs, and DADs. The arrhythmia is maintained by some different possible mechanism: local ectopic firing, single circuit reentry, and multiple circuit reentry. It is believed that over time, the arrhythmia itself causes remodeling of the atrium, which encourages the arrhythmia to become chronic, as opposed to the random bouts of it that patients usually experience when it first appears. Much of the treatment for atrial fibrillation includes cardioversion, medical conversion, or rate management, meaning we no longer try to bring the patient out of the rhythm. In all cases, anticoagulant therapy must be a part of the treatment plan. Consistent monitoring of INR levels, meaning blood tests all the time, is a huge disruption to patients' lives. Many patients are also very symptomatic with the arrhythmia, whereas some tolerate it well with proper rate management. Atrial fibrillation ablation procedures are offering a better solution for many patients. When AF ablation was first introduced, it was reserved as a last-line therapy for highly symptomatic patients who were refractory to all other options. With the recent success of these procedures offering a possible long-term cure, it is now being offered to select patients as a first-line therapy. Current success rates are quoted around 87% at 1 year follow-up and 63% at 5 years follow-up. The usual target areas ablated is around the openings of the pulmonary veins and the left atrium. For more information, do some research into the maze procedure.
This flowchart shows the general progression of and modern categorization of atrial fibrillation based on how long the arrhythmia persists and the treatment required, if any, to get the patient back in sinus rhythm. Take note that many texts will still refer to permanent AF as chronic AF. One of the main goals of AF ablation is to improve the patient's quality of life as well as reduce stroke risk. If the patient is asymptomatic or only mildly symptomatic with AF, they are less likely to experience a positive change in their quality of life from a pulmonary vein isolation ablation. It's generally accepted that the type or level of burden of AF, categorized as paroxysmal, persistent, or permanent, affects the efficacy of the procedure, in that patients with less AF burden respond better to PVI ablation. The older a patient is, the more dilated their left atrium is, and the longer a patient is in AF, more maintenance mechanisms can develop, which can make the procedure less effective at preventing recurrence of the arrhythmia. Pulmonary vein isolation, PVI, can be done by RF, heat, or cryo, cold, and this case was a cryo procedure. In the EGM pictured, what we see is a catheter named PV that is located inside a pulmonary vein, and the CS catheter showing left atrial activity. The pulmonary vein is in fibrillation and is transmitting multiple PACs to the left atrium. This is the most common trigger for atrial fibrillation. As the cryoburn is applied, electrically isolating this vein, the signals are blocked from exiting the vein, and sinus rhythm begins to prevail.
Atrial flutter is a fairly common atrial arrhythmia and recognized by sawtooth-shaped waves on the baseline of the ECG. These flutter waves are best seen in leads 2, 3, and V1. In the typical form of atrial flutter, the waves will be pointing downwards in leads 2 and 3 and pointing upwards in lead 1. The atrial rate is between 240 to 400 beats per minute, usually closest to 300. Due to the refractory period of the AV node, the most common ventricular rate of new onset atrial flutter is 150 beats per minute, or half that of the atrial rate, causing a 2-to-1 conduction ratio. Typical atrial flutter is defined as a macro reentrant circuit that travels in a counterclockwise direction within the right atrium. Reverse typical atrial flutter or clockwise atrial flutter is described as a large reentrant circuit in the right atrium that travels in a clockwise direction through the isthmus of tissue located between the tricuspid valve annulus and the inferior vena cava. On the ECG, we observe upright flutter waves in the inferior leads. Triggered activity is the final abnormal arrhythmia mechanism. Triggered activity contains features of both abnormal automaticity and reentry, but often thought to be a subgroup of automaticity arrhythmias. We will focus again on the action potential. With regards to leakage of positive ions during late phase 3 or 4, this facilitates enhanced automaticity and creates after depolarizations known independently as early after depolarizations or EADs and delayed after depolarizations or DADs that have the potential to generate another action potential if the depolarization is sufficient to reach threshold. Reentry characteristics seen with triggered activity include the provocation of premature impulses. This allows for ease of study within the EP lab as we can reproduce these parameters, but does create difficulty to distinguish the mechanism as multiple characteristics are observed. The image shows the differences seen with action potentials displaying after depolarizations. EADs will show an earlier bump in the action potential, and DADs will show a later bump in the action potential. We can further discuss the different conditions associated with these after depolarizations. Pause-dependent triggered activity is noted with the occurrence of early after depolarizations that are typically related to conditions prolonging the action potential, such as electrolyte imbalances or use of 1A and class 3 antiarrhythmic drugs. The most significant polymorphic VT seen is torsades de Pont. Remember, if the QT is prolonged, it provides an opportunity for an R on T phenomenon. The goal of treatment is to prevent prolonged duration of the action potential. Catechol-dependent trigger activity is noted with the occurrence of delayed after depolarizations that are typically caused by digitalis toxicity, cardiac ischemia, and some observations of long QT syndrome. High sympathetic tone can transiently enhance the propensity for PVCs and catecholaminergic polymorphic VT. The goal of treatment will consist of beta blocker therapy or an ICD. Polymorphic VT such as torsades and CPVT. That takes us to the end of this presentation on Electrophysiology Foundation, session 1.2.